Sorry. So good morning, everybody, and welcome to Clinical Rounds this morning. For those of you I have talked to before, my name is Holguin. I'm a pretty long-standing member of Firestone, although I've been doing other work for the past while, so I've not spent as much time here as I should. But it's a pleasure to be back and have an opportunity to introduce a colleague and a friend who's visited us from the University of Colorado, Dr. Fernando Holguin. Dr. Holguin is an endowed professor of medicine. You see, you have James C. Campbell Professorship of Pulmonary Medicine. It's kind of nice that he's giving this presentation in the Campbell Auditorium. I was giving Fernando a little bit of the history of Warren Campbell and his time here at Firestone, and so it's a nice sort of congruence of events that we're doing this in the Campbell Auditorium. He's a practicing pulmonologist and critical care physician at the University of Colorado, the Anschluss Medical Campus. Fernando originates from Mexico City, where he went to medical school before undergoing training in pulmonary critical care medicine at Emory University in Atlanta. During that time, he worked as a medical epidemiologist in the Respiratory Health Branch at the Center for Disease Control and Prevention at CDC. Obtained his MPH in epidemiology at Emory's Rollins School of Public Health. Dr. Holguin transitioned to the University of Pittsburgh, where he gained expertise in asthma clinical trials and airway epithelial cell biology before eventually joining the University of Colorado to establish the Severe Asthma Program and direct the Latino Research and Policy Center. His research is primarily centered on air pollution and its associated health effects, as well as translational clinical studies related to asthma. Fernando recently, about a year ago, took on responsibility as the division head for pulmonary critical care medicine at the University of Colorado. He's also very active in professional organizations. He co-chairs CHEST, the ATS task force, focused on severe asthma, recognized for his leadership in the ATS, having served as the Assembly Program Chair for environmental and occupational respiratory health and airway inflammation and immunity. He's also the ALL Assembly Chair-elect and has contributed to diversity and equity initiatives throughout Health, Diversity and Equity Committee. 2022, he received the ALL Scientific Accomplishment Award. Dr. Holguin's research is well funded, as it should be. It's quite outstanding, written by the CDC, NIH, DoD, ALA, and EPA. He's also currently the associate editor for the Blue Journal and has authored more than 200 peer-reviewed publications. Fernando is an outstanding scientist. He's an administrator. He's been a really good friend and colleague, and I'm delighted to welcome him to Hamilton, to McMaster, to Firestone, and invite him to present his presentation.
Thank you, John. Good morning, everyone. Thank you, Paul. Thank you for the kind introduction. I'm delighted to be here with you. When Paul invited me, I have to confess I was a bit intimidated to give a clinical talk at the Firestone Respiratory Improvement. This place really contribute most of the seminal work, as you know, in asthma and airways diseases. So instead of not coming short to the expectations, Paul, I decided to do a talk that I think, given the political climate, has more relevance to talk about respiratory health disparities. So it won't be all around asthma, and I'll touch a little bit on some of the, some of the environmental inequalities and racial injustices that are associated with different outcomes in respiratory health, mostly in the United States, but I think some of it might be applicable also in the United States as well. So I think I'll talk about some of the most important respiratory health disparities and then summarize, what are some of the environmental risk factors that make minority populations more likely to experience disparities, and then talk about systemic and structural racism in healthcare and how those also play a role in health disparities, in respiratory health disparities, and then talk about some strategies to mitigate some of these discrepancies in outcomes. So if you look at the CDC, their definition is that the health disparities are preventable differences in the burden of disease. That includes also injury, violence, and opportunity or lack thereof to achieve optimal healthcare that is experienced by socially disadvantaged populations. And as you know, these events are always sort of mirrored and affected by the current political and historical climate. There are many things that disparities result from, including poverty, environmental threats, inadequate access to healthcare, individual and behavioral factors, and educational inequalities, and they all contribute to what disparities are. But if you look at health disparities as a sort of a topic, it's really complex. And as you can see from here, it has many factors to it. It makes it very hard to study. It makes it very challenging to measure, and it makes it even more challenging to intervene on it. So there are factors that relate to age, violence, living conditions, ethnicity, insurance, mental health, and so on. You can name all these factors to play a role. The National Institute of Minority Health and Health Disparities, which unfortunately will disappear, created this sort of scheme to try to understand and provide a framework as to how to understand health disparities. So here, for example, you have that the proximal factors that relate to biological responses in an individual, for example, those that may suffer from higher obesity prevalence or hypertension or are more stressed, all the way to individual demographics such as age and socioeconomic status, and then intermediate factors that relate to physical context, the building that you live, the pollution around you, the type of social networks that support your environment, that they provide you access to health when you're sick, and then also all the way to distal factors, which are sort of institutional context and the way people are treated when they go to the hospital. This is a good framework, but if you think about it, it seems like these things are somewhat separate from each other. And the reality is that they're very much intertwined. It's not that the proximal biological factors live in the bottom and the institutional factors live at the end. These are all things that happen to interact all the time with each other to create disparities. So Krieger came up with this ecosystem approach that I really think fundamentally explains disparities at a much lower level. And I think it sets a tone for this talk. If you think about it, there are ways of living and working that are differently afforded by different people, right? Both in Canada and the United States, and that it's determined by economic, political, and social relationships. So many other factors play into this, such as class, racial inequality, that are differentially affect living standards and working conditions and environmental exposures. And at the end, what you is these factors result in an ecosystem in which you have many different things that affect respiratory health and health in general, such as access to healthcare, racism, prejudice, discrimination, the degree of biological responses in the individual, social determinants of health, and then environmental exposures. And what happens is that in disparities, because of this ecosystem, there are differential societal patterns of distribution in disease. And this not only affects the individual, how an individual experiences these exposures or these factors, it really does span across the lifespan. So for example, there's data that health disparities, for example, stress under pollution can cause epigenetic changes that are transmitted to the offspring. And then certainly many of these impact childhood and lung development and growth into adulthood and then into the elderly. So the effects of whatever causes disparities go across the whole spectrum, from birth to in utero to aging. And these are respiratory health disparities are a major health problem in the United States, and unfortunately have not persisted but have gotten worse over time, according to the report in 2021. And I'll just show you some examples. This is data, national data from JAMA, looking at over 160,000 individuals, adults, where you can see that the prevalence of asthma in quintile 1, which is the lowest income, the prevalence has gone much higher compared to those that are higher income distribution. And that sort of, if you look at it, it's clearly gotten worse over time. And the same can be said about COPD. This is again COPD prevalence by income, showing that those in the poorest strata, which is quintile 1, have a higher prevalence of COPD. And the effects are notable also when you look at how much people lose. As all of you know, we tend to lose about 30 cc's per year if you don't have 20 to 30 if you don't have any problems, but you can, even your environmental exposures, you can lose a lot more lung function. So these are the slopes of lung function regressed in different, comparing the lowest quintile to the highest quintile of income. So over time, from 1971 to now, people in the poorest strata of society have been losing consistently more lung function compared to those that make more money. And that same thing is true for women, although to a lesser extent. The reality is that many communities across the US experience great burden of respiratory disease due to worst environmental exposure, resulting from historical discriminatory and racist policies. I'm going to talk a lot about this today. So here are some examples, and I think Paul Hamilton may be an example of this, where industries like Pittsburgh still news play a major role, and you can see them in close communities. And if you think about it, many of these industries are not close by affluent communities, but they're close near poor communities. And so here's another example in how poor communities in the United States are broken by freeways and are isolated by freeways. And that didn't happen by accident, as you see, it happened by design. And many communities have very poor housing conditions that also relate to indoor environmental exposure and process. So I don't know if you're familiar with this process, but the Homeowners Loan Corporation, HOC, was part of the Theodore Roosevelt's the new initiative following the Great Depression in the United States to try to revamp economic investment in the cities. And what they did is was a way for the government to invest and back up loans in the cities so people could build homes and afford them. And that led to a great expansion on people owning homes in the United States and the growth of living headquarters across the country. So, but one of the things that the HEOC did is they generated security maps which categorized neighborhoods into 4 categories. They were best, desirable, declining, or hazardous. The hazardous ones, you can see this is an example of Denver. You can go online and download any map in the United States, and you can still see the areas that were red zoning or green zoning. So the green areas were the good zones. This is from the 1930s. The blue were desirable, the yellow were declining, and the red were undesirable or hazardous. And of course, all those areas were areas that had predominantly Black neighborhoods and brown neighborhoods and were deemed hazardous and were outlined in red. And what happens is when an area was outlined in red, it did not give the investors confidence that money should be invested in there. So no money was invested in those communities, and they lagged behind in terms of growth and development. And there was actually a manual to support this project, and I read some of this manual, and one of the phrases that stuck to me is that the infiltration of inharmonious racial groups will lower the level of land values and lessen the desirability of residential areas. So not only would people be told you live in an undesirable area, but they were sort of not encouraged for people to move from a red area to a green area or a blue area. And that has had profound impact on where we are today. This is the red line in maps today. So if you look at areas here highlighted in this red square, the hazard areas, 63% in the United States, right now, people living in that states are from minority groups, mostly Blacks and Latinos. And then the majority of them, which are here, represented in the gray bars, are considered low to middle income individuals. So many of these red areas since the 30s have remained areas where there's a lot of minority presence and people with low income. There are a lot of great projects. I want to show you some of these results. This again, Denver, the red line district. And things have changed over time. So this is Denver in the 1930s and Denver now. And you can see that there's a lot more green areas, so more desirable areas. And there's some persistence of red areas. But many of the yellow areas have become green areas. You could think that that's sort of social economic growth, but in reality, this is a process of gentrification. So it's another way of social injustice and inequality. Red line and segregated areas, people that live in those communities experience a great deal of the environmental risk factors and exposures that are associated with disease, including poverty, unemployment, high crime, high levels of traffic and industrial air pollution, poor housing conditions. So for example, this is an article from the New York Times showing Oakland, California. You can see the red line districts have a much higher concentration of nitrogen dioxide on average compared to areas that are not in the red line districts. So the RAND Corporation has a great project in which you can actually go today and see some of the environmental disparities that many of these areas experience. So for example, if you live, this is Denver, again, I'm showing you the case for Denver, but you can look at any city. In Denver, for example, if you live in a red area, you're more likely to experience high levels of particulate air pollution and diesel exposures, and you're much more likely to live near a Superfund. So these are EPA sites like waste disposals and toxic areas and garbage disposals. So again, this is some of the red and yellow areas in Denver that show that if you live in these areas, your proximity to traffic is a lot more closer and you are exposed to much more traffic, air pollution. So more cars, more proximity to major thoroughways. And that has an implication that I'll show you in a second. This is a study that we just completed. If you ever go to Denver, you have to go through an avenue called Colfax. Before they built the highways, Colfax was the only way to the mountains. And so you'll see these very 60s, 50s looking motels, which many of them have become poor housing right now because they don't use as motels anymore. And so the community asked us to do a study looking at children in those communities. So when I was leading the Latino Health and Policy Center, one of the studies that we did, we looked at indoor fine particle, indoor carbon, and other allergens in residential motels and apartments and single-family homes, and found that many of these motels have really poor indoor air quality, as you can see here. And that has an implication because if you live close to a road or you're close to traffic, it increases your odds of developing asthma or respiratory symptoms. So this study from Rob McConnell in California shows that, as you can see here in the graphic, the closer you are to a major distance road, the higher your probability that you're going to have asthma. So compared to those that live greater than 300 meters away from a major road, lifetime asthma increases by 85%, prevalent asthma almost by 2.5-fold, and current UEs almost by 3-fold. And we looked at that in Mexico City, this is Ciudad Juarez, where we looked at a cohort of 200 kids with asthma, non-asthma. Published a few years ago, you can see the dots here across El Paso. And we were looking at the effects of exposure to road density, close proximity, and the impact to respiratory health and lung function. What you can see here, this is the percentage in road density, and then the buffer radius. So kids, for example, that are exposed to, this is their homes, that are exposed to high traffic within 50 meters of their home, have much higher levels of exhaled nitric oxide associated with airway inflammation, have reduced lung function compared to healthy controls that are the gray dots, and have reduced FEDC. So again, chronically, if you're exposed to traffic within 50 meters to your home, you have a lot more likely to experience lung function and airway inflammation if you have asthma. The New York Times did this really great piece where they talk about global warming and the effects that redlining had to do with it. So what you're seeing here is that these are, I think it's downtown Richmond, Virginia. And you can see that the red areas, which are also redlining areas, are also, this is a heat index map, have the highest heat concentrations. And the reality is because one of the things that redlining neighborhoods do not have is enough tree canopy. So you can see here, for example, compare the red districts compared to it's clearly visible to the eye that if you live in these red areas, you have a lot more tree coverage. And that leads to the fact that there's a very large surface temperature level by these grades. So if you live in a green area, you're about 2 to 3 centigrade degrees below than if you were living in a red area. And that's a huge amount of heat. And so here's, for example, in Denver, if you live in the red area, you have much higher exposure to, and most of it is sort of island surface heating. So again, more pollution, more heat in these areas. And that has major implications, as shown here by Mary Rice from Harvard in this really nice review that shows that heating is associated with increased rates of asthma and COPD exacerbations in addition to other respiratory diseases. So now, what is the particular implication to a disease to asthma, for example, in terms of redlining? So this is a study that was done at UCSF, where you're looking at in San Francisco, San Diego, and Los Angeles, and you're looking at all these different great neighborhoods, the red areas, the green areas, and then you're looking down here at asthma prevalence. And if you just look at these maps together, you can see that the red areas have a lot more asthma in them compared to the green areas. And that translates also into emergency room visits. So compared to, this is the Nita-Takus group, those in red areas are more likely to experience a higher rate of asthma and ED visits compared to those that are in the green range, adjusted for other factors. So you clearly see that all these environmental exposures that are in these less desirable quote-unquote areas lead to a great burden of disease and comorbidity. Sally Wenzel and Alexander Schulier recently published a very nice paper using the asthma. I used to work here We had a very large asthma institute biorepository, and we had geolocated the addresses of these individuals, so we knew where they were living. And so this is a map district of different zones in Pittsburgh. So what you see here is the red areas and the good areas, not a lot of green, as you can see, because Pittsburgh used to be a steel town. It's a lot of red and a lot of yellow. Here used to be the steel mills used to be across right by the rivers. But what you can see here on your right side is that if you live in a red area, currently you're exposed to higher PM2.5, higher volatile organic compounds, more sulfur dioxide, more carbon monoxide exposure. And that translates into the fact that people with asthma that live there are more likely to have uncontrolled asthma, shown here in red proportion, are more likely to be exacerbation-prone asthmatics. They have more symptoms all the time. They miss days to school or work for asthma more frequently. They're also more likely to have current diabetes. And they're more likely to have eczema, and they're more likely to have received immunological therapy or Xolair therapy. So clearly you can see the people in this area with asthma have much more severe disease compared to the green areas. But one of the things that I found striking about this study is that when you look at people that are black or white, within the same red line area, blacks still do worse than whites, suggesting that it's not only an effect of environment, but it's a combination of environment and race or racism. So here you can see, for example, compare whites to blacks, they have more likely to have uncontrolled asthma, exacerbation from asthma. They're more likely to use daily short-acting beta agonists, which are associated with worse asthma outcomes, and their lung function is reduced. And it gets even more complex because it's not all about environmental exposure, but it's also our exposures to violence. So in this particular study shows the incident rate ratio of being exposed to a firearm incident in different parts of Boston. I think this is Newton and Cambridge in Boston. And so what they looked at is how many occurrences of firearm violations or shootings or events happen in red areas compared to other areas. So for example, if you compare red versus green, you're more likely, if you live in these areas, 3 times more likely to have to experience some exposure to gun harm or firearm. And some of the factors in the mediation analysis that explain this to be poverty, poor housing, black share of the population. And why am I showing you firearm violence? Because it connects to other environmental exposures. As shown here in this study by Jane Cloverty and her group from Harvard, where they followed a cohort of kids in Boston for over 18 years, 430 kids, and they looked at cumulative nitrogen dioxide exposure, which, as you know, is a marker for vehicular emissions. So what they found is that overall nitrogen oxide exposure, looking at the year of diagnosis, was if you did not have exposure to violence, it didn't really increase your asthma incidence. However, if you had exposure to ETV means exposure to violence. If you had exposure to violence, and in this case it could be gunfire or physical hearing gunshots or verbal abuse shown there at the bottom, your asthma incidence went up to 2.5%. So 2.5 times. So we know, for example, that stress is a huge risk factor for asthma morbidity and asthma incidence, particularly if you pair it with the environmental pollution. This has been replicated in other studies. I'm going to pivot a little bit and go from environmental exposures to talk about more structural racism and race. And so structural racism are forms that are pervasively and deeply embedded in systems laws, whether written or written policies, and are entrenched into practices and beliefs that produce, condone, or perpetuate widespread unfair treatment of oppression of people of color without adverse health consequences. So systemic and structural racism impacts how we ascertain health. I'm going to talk a little bit about that. It leads to inequities in treatment, diagnostic evaluation, and referral. I'll use some examples of that. And then it causes chronic stress, adversely impact health and well-being. So I'm going to talk about all these 3 examples about how structural and systemic racism influences these aspects of health. It's a great paper. If you haven't had an opportunity to read it, I would urge you to read this. This is a phenomenal piece that was published in the New England Journal of Medicine not too long ago, where they talk about race correction in clinical algorithms. So, as you know, we have clinical algorithms for everything, right? We have a race correction for creatinine clearance. We have a race correction for many cardiovascular outcomes. And we have a race correction for spirometry that has very deep-rooted historical factors in racism. I'll talk a little bit about that. So these are algorithms and practice guidelines that adjust or correct for a patient's race or ethnicity to individualize risk assessment and guide clinical decisions. So if you take it just at face value, it actually makes a lot of sense that we would use things for Blacks because it probably says something about their health that's more accurate. But the reality is that there's more genetic variation within racial groups than between them. And race does not equal biology or genetics. It's more about complex social constructs. So racial differences found in large data sets are more likely to reflect the effects of racism and not race. So the authors conclude, and I completely agree, that race adjustment does nothing to address the cause of disparity, but instead, these adjustments deter clinicians from offering clinical services to certain patients. And they risk propagating inequity into the healthcare system. I'll show you some examples of that. So I'm going to go and talk a little bit about history. If you have an opportunity, since you're all respiratory personnel, if you have an opportunity to read Bringing Race into the Machine, it's a great, great book that talks about the historical racism of spirometry and how it came to be in terms of race correction. I'm going to talk just a little bit briefly because the history is very interesting. So Thomas Jefferson in 1785, in the notes of the state of Virginia, suggested that the structure of the pulmonary apparatus was different among Black slaves. As you know, he was a slave owner. Now, note that was just his observation. He did not have any data to back it up. Samuel Cartwright, who's a physician that worked in New Orleans, took some of these ideas and wrote a paper in the 19th century that promoted the fact that the Black people had pulmonary deficiency. This is the original article that reports on the diseases and physical peculiarities of the Negro race. This led to, so this is the time that spirometry was being developed in England and then came to the US. And this is one of the first deployments of the spirometry in this country. So Benjamin Gold in 1964, as part of the US Sanitary Commission, was told to go and measure the vital capacity of Civil War soldiers, sailors, and prisoners and students. Now he measured, I guess, an incredible study, 21,000 people. And he concluded, as you can see here, that those were labeled as full blacks and mulattoes had lower vital capacity. But the problem is, as Philip Quainger wrote subsequently on this paper, Philip Quainger is one of the fathers of, as you know, spirometry and lung function testing, that what Benjamin Gold did not do is he didn't adjust for the fact that people who were blacks during the Civil War were incredibly malnourished, severely malnourished and in very poor condition. Many of them had tuberculosis and lung diseases. So many of them had terrible environmental exposure. So of course they're going to have viral capacity, low viral capacity, but it wasn't because of the race, it was because of their exposures, which were not accounted for. So these studies eventually conclude that pure blacks had inferior viral capacity because their viral capacity was found to be 6 to 12% smaller than whites. And that led to current spirometry race correction that we use today, fortunately less and less. So these served as the foundations to justify race adjustment for lung function equations. And this has tremendous implications. This is work we did at Denver. Daniel Colonida, one of our fellows, and Matthew Griffin led this study in which they looked at 33,000 patients that are listed for lung transplantation from UNOS and looked at people with IOD that were waiting for lung transplant and recalculated spirometry values in Black patients using white scopes, right? So they took the black correction and put white correction for a Black patient. And that resulted in a higher 1.9 higher lung allocation score, which basically means that because we race correct, Black people waiting for lungs weigh 20% in average more. So the same race correction that we're trying to do, because we think it's better for them, is actually being harmful to them. And this is a very specific example. It was just recently published in CHEST. This is a study from Spiromics, basically showing that the current race correction for African Americans underestimate the disease severity of COPD. Shown here is a COPD assessment test and lung function, showing how the red bar, which is the race correction for African Americans, underestimate symptom burden, the 6-minute walk, and underestimates radiographic airways disease. And this has potential implications for how we insure people, how we treat people, and how we transplant people. So there are many growing interacting factors that include, inequality and poverty, inequities in healthcare. And this population bulletin that was published not too long ago shows that over time, from 1989 to 2012, the proportion of high inequality, high poverty distribution across many different municipalities in the US continues to increase. So this is an ever-growing problem. And just to highlight, this is a study that we did when I was working at the Center for Disease Control in the Respiratory and Reproduction branch, which does not exist anymore, I'm afraid to say. Just showing that the percent emergency room visits for asthma and the percent using daily short-acting beta agonists is much higher in Blacks compared to whites and Hispanics. So those that are Blacks here on your left side are less likely to use immunocorticosteroids, but yet use the emergency room more often. So out of these 14,000 kids from the National Asthma Survey that we used at CDC, Hispanic children reporting using ICS in the past 3 months, 20% compared to 33 in white children, and also 26% of Black children, and 19% of Hispanic children reported receiving a daily dose of short-acting agonists compared to only 12% in children. So a lot of disparities in how people are being treated. And unfortunately, I think that this is going to, and I have to say, Paul, this is out of our own in a bit. Some of these inequalities are only going to get worse because, as you know, if you look at the new GINA guidelines, some of the work that Paul has done with the group recommend the use of smart therapy, which is phenomenal. And it makes a lot of sense that we use anti-inflammatory rescue therapy because it leads to better outcomes in severe asthma. When we use MART, but the problem is in countries like the United States, this creates a major problem in terms of access to medications because albuterol costs between $30 and $100, whereas for motor or budesonide it costs between $230 and $400. That means that many patients will not be able to access MART therapy or anti-inflammatory rescue therapy. So there will be, and this comes into the doorsteps of the fact that the FDA just approved a couple of years ago inhaled epinephrine for over-the-counter. So we're going backwards instead of going forward, I'm afraid. Racism in medicine affects many things, and it's very broad and it's very powerful. As highlighted in this excellent New York Times report on 2021 that talks about racial inequities persist in healthcare despite expanded insurance. For example, one very well-known example is that Black women have the worst perinatal outcomes of any other race group in the United States. And people for a long time sort of ascribe that to poverty, but the reality is that even women that are Black that are wealthy exhibit very poor perinatal outcomes. And this led to a wonderful book that a journalist in New York Times published, where he followed Black women across different types of scenarios and practices. And what they found is that providers, there's a lot of implicit biases in the ways patients are treated that cause a lot of stress that leads to perinatal outcomes. So, and that changes when we know, for example, Black patients opt for more preventive care when the physician is Black, and mortality rates for newborns drop when they're cared for Black physicians. So what is the effect, for example, of the stress in some outcome related? Stress can be very traumatic with pathological pathways that are now better understood in terms of airway disease implications. So in this study of almost 3,500 children in the United States, those are African American that have some degree of perceived discrimination are almost twice as likely to have asthma. And those that have often experiencing discrimination are almost 3 times more likely to have asthma. So asthma and stress and racism are intimately related to each other. Now let's talk a little bit about the other side of the equation, which is the treatment aspect and the screening aspect of it and how we evaluate patients. So the Institute of Medicine published this report that's called Unequal Treatment. And I'm just going to summarize the main message is that we know for a fact that the quality of healthcare is different across minority or non-minority populations. And this difference between these two groups is largely explained by the operation of the healthcare system and its legal and regulatory climates, and by discrimination, including biases, stereotyping, and uncertainty. And this leads to disparity in the healthcare system. So again, going back to redlining, this is a redlining district study in Boston showing lung cancer screening across areas. And what it shows is that in red line areas, Black women had 61% and Black men 47% lower odds of lung cancer screening compared to white men or white women in red line areas as well. And that has also important implications of implicit bias and how patients are perceived. This is a really wonderful study where they looked at once a patient goes to a physician and has a lung nodule, how long does it take for that physician to refer the patient to surgery or further evaluation for treatment? And so here is if an African American patient is seen by a white physician, the average lag day of referral is for 500 days. That's a year and a half. But it's not only about white-black. In this study, if a Hispanic patient is seen by an Asian physician, the lag time is about 750 days. And this is not at all explained by any of these confounders. A tremendous amount of how physicians look at someone based on their race and decide the speed as to why someone is to be referred. And nationally, this has implications for lung cancer treatment. This is from the SEER registry in the United States that showed that Black patients are less likely to undergo staging, and then once staged, they're less likely to have surgery compared to whites by almost 50%. So here you see that Blacks compared to whites, surgery is often not recommended for Black patients, even though it's less often contraindicated compared to white patients. So tremendous disparities in lung cancer screening and in treatment for lung cancer. Now, one of the things that you see when you dive into the literature of disparities, and there's very easy to talk about, right? With disparities, you can easily quantify that something is different or unequal across different groups, but it's very hard to talk about ways to reduce it. Because of the complexity of disparities, it involves politics, it involves money, it involves society, it involves many, many things that are outside of what we do in clinic. So it's very difficult to reduce disparities. So I did, as they say, as some people would say in the US, I did my own research. So I looked at papers in PubMed that talk about just respiratory health disparities anywhere in the paper. So you see that in the past few years, and this is per year number of papers published, it's really gone quite a bit. But if you have the words reducing respiratory health disparities, it goes down by 78%. So there are only 440 articles published, 440 that actually specifically talk about how to reduce respiratory health disparities. So again, much easier to explain, very hard to fix. The MMWR published a series of strategies as to how to reduce health disparities in 2016. And they come up with 6 key components to effective public health program implementation. For an effective program, it has to be innovative, provide a technical package of evidence-based interventions, talk about performance management, partnership with communities, lead to effective communication and political commitment. And I would add that these interventions have to be cost-effective and sustainable. They have to be driven by program evaluation and driven by outcomes. They have to include dissemination and community involvement. And they have to include system-level interventions that involve structural racism and inequity for them to be successful. But they are successful. This is MMWR, one of the studies that they highlight is this community asthma initiative that partnered with a community in Boston, and it showed a sustained over 1 year reductions of many levels of asthma outcomes, including emergency room visits and missed school days. And so interventions that are designed to partner with communities that evaluate individual needs with appropriate cultural sensitivity have the greatest possibility for long-term health. But it's also very important, if you look at about many of the studies that we do, this is an official thoracic research segment that we published a couple of years ago, in which one of the issues is that we have serious problems enhancing recruitment and retention of minority populations for clinical research in pulmonary and critical care in medicine. If you look at most of the research, highly underrepresented. So we came up with a package of recommendations to enhance minority representation in a way that is also meaningful to different populations. It also matters who is taking care of the patient. So this is the distribution of graduates by race and ethnicity in the United States by 2018, 2019. As you can see, the purple is whites, 8% and 5% are Blacks and Hispanics. And so very little underrepresentation for Hispanics and whites, considering that Hispanics the largest minority in the United States, followed by blacks. And so there's this initiative. So if you ever have an opportunity to look at this website, it's fantastic. This initiative run by black physicians in the United States called Black and White Coats that are universities that participate in multiple events, do a great job trying to get particularly black men into medical school. W.E.B. Du Bois was an American sociologist that was way ahead of his time. He was one of the first people that said we should not be dividing people into black or white. It's a mistake, and it has nothing to do with race. So he wrote a lot of wonderful papers, some of his books, some of his manuscripts, because he sort of, a lot of his writings, if you read them, came out at the end of the slavery, and then sort of as we moved to a more of a civil unrest, and there were a lot of things that, even though slavery was officially ended, a lot of things remained in society that were disadvantaged to African Americans. So when in one of his books he defines race as a vast family of human beings, generally with common blood language, always with common history, traditions, and impulses, who are both voluntary and involuntary striving together for the accomplishment of certain more or less vividly conceived ideals of life. This is the best definition of race I've ever read. It has nothing to do with genes and genetics or color of the skin. So one of the proposals is that we as researchers and as healthcare providers abandon the idea of race and focus on racism. So the deeply rooted belief is that race, as determined by phenotypical characteristics like the skin of color or facial features, reflects fundamental biological differences, when in fact does not. That's been proven over and over again through genetic ancestry testing and other factors. So we must continue to collect and analyze data on the population groups that have been racialized into socially constructed categories called races. We must not, however, continue to use that term. It is not only an obstacle to dismantling racism specifically. And so this is from a great paper that talks about abandoning race and focusing on racism. The American Journal of Epidemiology recently published the percentage of papers that deal race and ethnicity in their studies. When I was an epidemiologist at CDC, you could not present any point estimate without race adjustment. So like you would show an odds ratio, so people would be like, did you adjust for race? But people don't take it like, when you adjust for race, what are you really adjusting for? Race is not a biological discriminant factor. So what are you adjusting for? You're adjusting for things that are actually part of what you're trying to understand. So you're doing a disservice to studies by adjusting for race in a way. So, in this analysis, what they found is on these 329 survey of studies in epidemiology, only 4 studies defined race or ethnicity, and only very few studies defined why they were doing race and ethnic adjustment. It's sort of in epidemiology becomes sort of a de facto automatic thing, adjust for race. Why are you adjusting for race? When you do an epidemiological analysis, take a step back and say, should I better understand the outcomes across different race groups than adjusting for race? Right? It's different by far. Implicit bias is really pervasive in healthcare. So it's very common and it has a negative impact on patients from a stigmatized group. So we know that implicit biases, these are things that you perceive about somebody based on their race that you may or may not be conscious about, but that defines your actions when you interact with people. That's what implicit biases are. For Black patients, it's associated with negative ratings on clinical interactions, less patient-centeredness, poor provider communication, under-treatment of pain, use of Black patients as less medically adherent than white patients. And in education, 48.7% of US medical students surveyed reported having been exposed to negative comments about Black patients by attending or rescuing physicians. And that ultimately translating the fact that students demonstrate significantly greater, not less, greater racial bias in year 4 than in year 1. So students see their attendings treating people that are Black differently, they learn, and then they uptake some of the same behaviors. Unfortunately, many of the things that I mentioned, really sad to say this, but are going to get worse. As many of you know, I have to rehash the news, but in the United States, we're living with a very drastic ideological approach to health and environmental risk factors and disparities. All of our grants on equity, inclusion, and diversity were terminated, including our grants for COVID, tuberculosis, and HIV. So it's a really tough time in academic medicine in the United States. And I just brought you some examples. The Biden administration had said a very large package of grants, totaling the billions of dollars, to reduce some of the environmental justices that the home loaners, the great deal of Ted Roosevelt in the 1930s had cost people. So these redlining effects, if you will. And they have all been terminated by CELDI, including the EPA. So the EPA has canceled all the environmental justice. So it means that many of the things that were tackling some of these problems that I talked to you today are going to get worse. So I think it's a wide belief that these Trump-led attacks on equity are going to set the stage for our next public health crisis that is going to take potentially many decades to fix. So in conclusion, I just want to give you some thoughts. Respiratory health disparities in vulnerable populations result from the chronic exposure to environmental, societal, political, and structural inequities. It is a major public problem, not only in the US, but in many parts of the world. Respiratory health disparities can and should be prevented by multi-level interventions that partner and fund the communities to ensure sustainable, scalable, and culturally sensitive interventions. As researchers, and this is something we all can do, and healthcare providers, we need to change the concept of race from being a biological determinant to understanding it as a social construct. It's more important to know somebody's perceived experiences because of their race than their race itself, than the race itself. And then lastly, current budget cuts, by undermining the costs, will exacerbate and worsen respiratory health disparities, unfortunately. And I leave it at this. So thank you.
Wow, it was a great year to think about, Fernando. Thank you so very much. One thought I crossed my mind, and maybe again, the questions or comments. We have, of course, a very different healthcare system in Canada, single payer system. We hope improved access, ease of access, so forth. But about 15, maybe 18 years ago, a colleague from Firestone, Johnson, published a series of articles in our local newspaper that was speculating called Code Red. You will remember that series of articles about health disparities in our red line, which is just sort of northeast of the city, and identified a number of very major disparities. It fit beautifully with the slides that you showed us. And this resulted in a lot of angst and investment. The city put some investment there, trying to put access to primary care physicians and so forth. 10 or 12 years later, he took the survey, no change.
No change.
No change at all, very sad. And it struck me that one thing you said is really important. I don't know what was done, to be perfectly frank, but I doubt very much that the community themselves were all that involved in planning strategies around which change would be attempted.
Right.
And you made the point very clearly that you don't do that,
Doesn't work.
it's not going to. So, questions or comments? Yes, go on.
Totally inspiring. Thank you so much. And such a deep data-driven deep dive. Just really wonderful. I can't say enough. I think, but I'll try to frame this as a question. You know, one of the things that I was really struck by is that we blame people for systems problems. And a major system problem is obviously housing and construction. And in Canada, we're about to start this major bill, the federal government's promised to build houses for everybody. And the thing I really worry about is the lack of planning about where, green space, access to roads, and doing strategic often come at the expense of this. And I've often thought that this group, clinician scientists and trainees, should be speaking to the importance of considering air quality in these sorts of federal government initiatives, because my concern is that in the rush to do things quickly was actually creating problems that my respirology colleagues will be having 20, 30 times looking for. And so, do you have any examples in your network of who've been involved with sort of urban planning, that sort of thing that we could maybe learn from.
Yeah, it's a great point, and you're absolutely correct, because we're doing this housing to try to like tackle a major problem, and there's no green spaces, there's food deserts, the built environment conditions to obesity and obesity to asthma, and they're perfectly some of the same problems. There are very few examples, unfortunately. One of them is Dr. Nita Thakur from UCSF. She's done a lot of really wonderful work with the community in San Francisco, where she partners with the community. Some of this has been published, which I, now that you give me that, I'm going to include in my next presentation. But they go back and actually with the community, they decide where, how many plants and trees to plant. So they have grants from the community, and the community goes in and plants them, and they have ownership of it, and they start to transform the landscape slowly. This is a long-term commitment, but this is the kind of projects the community is invested. They see their work there, and they value it and respect it, and it grows. So, but examples like those are very few far in between, unfortunately, because it's not something you can just throw money at it, because it's not going to lead to major changes. It's a very complex phenomenon, but you're absolutely right.
Yes, Fernando.
Thanks so much for that, Holguin. I'm interested in your perspective in terms of genetic ancestry markers. Do you think they have any role in epidemiology or research, trying to tease this apart between what is biology, what is epigenetic versus what's environment?
Yeah, it's a really good question. I'm not an expert in topic matter, but I used to be one of the asthma researchers. And when we did BAR, which was an England Journal of Medicine study looking at best approaches to treat African Americans, that were the randomized to different doses of corticosteroids and active beta agonists. We also took ancestry markers on all the patients. And what we thought that they were going to be informative in terms of response to therapy or effect modification did not. So I haven't seen any major breakthrough in terms of ancestry markers that relate to informing either healthcare decisions or response to medications. They're very interesting for if you have a 23andMe, because they can tell you where you come from. But right now, I see there's a big disconnect in some of these issues and ancestry markers.
Although I disagree with what most of RK has said in terms of its policy and different things, certainly there's a lot of things in the Make America Healthy Again initiative that are sort of interesting, great food for thought, one of which relates to processed foods. And in terms of where we often see a line amongst different categories of the population, a disparity in terms of what they're eating on a daily basis. I was curious as to whether or not in your data you had the granularity to be able to look at what's being consumed in terms of its association with asthma.
Yeah, I mean, there's data that's fascinating that I was not able to include because of lack of time. But if you go back to redlining and geospatial analysis, you can find a lot of data on food deserts and type of food that people consume. For example, there's areas where the only places you can buy food is a dollar store, which most of it is cellophane wrapped, right? So it's